Now moving on to our third section, that is the Physeal injuries. It's one of the very common injuries, especially in the case of pediatric population of the children. We'll be discussing what the different types of injuries of the Physeal, especially the Salter-Harris classification, then mechanism of injury and its diagnosis and treatment, along with the complications of Physeal injuries. Now, what are the injuries to the Physeal actually? As you know, that Physeal is present in the bones of the children, especially because this is the area from where the bone is going to grow. Especially there is epiphysis, which is just around the joint, then the physis, and then there's a metaphysis or the diaphysis. So classification is mainly based on the Salter-Harris classification, which actually gives us 5 types. What is type 1? Type 1 is actually a transverse fracture through the physis, through the hypertrophic or calcified zone of the physis, and usually the growing zone is not injured in most of the time. And growth disturbances is uncommon, especially in the type 1 Physeal injuries. In type 2, which is the most common type of Physeal injuries, if you see the bony chip is actually, this is a transverse fracture, but the fracture is not completely through the physis, rather it crosses from the physis, it goes into the metaphysis. If you see these two diagrams over here, this is the epiphysis, this is the physis, the physeal region, then the metaphysis and the diaphysis of the bone. If the fracture is going through this area, this is the transverse fracture type 1. But if the fracture line exits from going through the physis and then exits through the metaphysis, as you can appreciate over here, it is going through this and then exiting into the metaphysis, this bony chip, it can be appreciated over here as well. This is classically type 2 injury. That is toward the edge, it deviates away from the physis and goes into the metaphysis. Splits of a triangular metaphyseal fragment of the bone, as you can appreciate in this diagram, and this is called as Thurston-Holland fragment. This is very important because when we're going to be fixing this fragment, we need to be very sure that we do not damage the physis present over here as well, because if by any form of fixation, if we damage this physis, this is going to create angulation later on. Now coming to the type 3. Type 3 is that it's also splits the epiphysis. Now if you see these diagrams, the fracture is going through and through this, called as the surface of the physis is called type 1. From then it splits and goes into the metaphysis, this is called as type 2. Instead of going into the metaphysis, it goes into the epiphysis and it splits the epiphysis. This becomes a type 3 injury. Veers transversely are one other side, but usually from going through into the metaphysis, it goes into the epiphysis rather, and through it usually the hypertrophic layer of the physis, and this causes growth disturbances because these two both will cause the growth disturbances later on. Type 4 is a little different. Type 4 in the fracture is such that it is actually involving the epiphysis, physis and the metaphysis region. It's classically called as through and through fracture, in which all the three basic epiphysis, physis and metaphysis are involved. It splits the epiphysis, extends in from the physis to into the metaphysis, and usually liable to displacement. And there is associated with, because this region of the physis would be affected and this would grow, this would cause the angulation in this direction, because this area cannot grow normally and this will grow and push into this kind of a direction. Now this type 5 as well, which is actually crushed injury of the physis. There is a longitudinal compression in which the physis, there is a force acting on the top and on the bottom, and the physis in the middle is actually crushed. Not visible fracture, that is, there is no on X-ray, it appears to be normal, and the growth plate is actually crushed, and this results in a growth arrest. How we know that it was a type 5 injury? Because the growth was crushed, there will be no growth of this physeal region. This physis will grow and later on deviate towards this side, and this is the reason in retrospective when we review this Salter-Harris type 5 injury, usually they present with angulation later on, because the physis has been damaged. There's a crushing of the physis, there's no regeneration, and the other physis which is actually present or which is normal, it causes the deviation or angulation of the joint. Now mechanism of injury. Mechanism of injury usually can result from falls or traction injuries, mostly in the road accidents. You could be during the sporting activities, could be during the playground tumbles, multiple causes could be present as well. The non-accidental injuries includes could be due to iatrogenic injuries when we are doing surgeries around the unjoined periarticular areas. We can damage physeal, especially in the children, and probably proper investigations may not be done at the time of injury as well. Now, if you see, the X-rays are the first thing which usually make it easily visible when we usually get an X-ray as well. Sometimes physis, if you see this X-ray, this is the epiphyseal region, this is the physis of the distal femur, and this is the metaphysis. Now, if the fracture fragment would be going like this is probably Salter's type 2 injuries. If going into this way, this is Salter's type 3 injury. Usually you see as Salter has type 1 injury, which is through the surface of the physis. It could be totally normal as well. So if you're suspecting it's a normal, it could be a Salter's type 5 injury. The best is to actually get a opposite joint X-ray sometimes as well, especially in the case of elbow. Sometimes we are not sure about it. The best is to just if we are taken the X-ray of the right elbow and we are not sure, just take the X-ray, repeat lateral view of the left elbow just to compare it, so that we may elicit very subtle changes which may be visible on both the X-rays. Epiphysis usually incompletely ossified in the X-rays children. There are telltale features sometimes because the fracture line is exiting either into the metaphysis or into the epiphysis. Type 5 injuries, as I told you, are actually diagnosed in retrospective. If it's actually, let's suppose if this is crushed over here and now there will be no telltale sign, but later on once the patient would develop an angulation in form of a genovalgum, then probably we will know that there was a medial side of the injury, which may be Salter's type 5 injury. Coming to the treatment. Treatment includes splinting, cast or close fitting plaster for the slab if it is undisplaced. If it is displaced fractures, then we have to first reduce it. Then anatomical induction is mandatory. It could be a form of gentle manipulation under general anesthesia or immediate open reduction at time. If it is massively displaced, then we may require immediate open reduction. Internal fixation is usually with the smooth K wires, or screws can also be used, but we have to remember one thing, that if the fracture fragment is such that we have to go through the physis, then we're going to use the smooth K wires. If we are using screws, when you have to make it sure that we are not going through the physis, because screw placement through the physis is going to damage further physis. So for example, if the Salter has type 4 injuries, which is actually if through and through injuries, epiphysis, physis and metaphysis, then we can apply screws which are parallel to physis into the metaphyseal and into the epiphyseal fragments, but we have to avoid physis. If we are applying fixing them in which such a way that we have to pass cross K wires in form of which are going through the physis, then we have to use smooth K wires, because we cannot use the threaded K wires as well, because they will damage the physis. Now coming to the complications, why this is important? Because there usually results as children are growing. This can retard the growth, this can present with angulation, and there are multiple sorts of problems which can later on have implications in physeal injuries. The most common is actually damage to the proliferative zone, which means the bone cannot grow properly. Now these are other options, a malunion or non-union, because there is no bone cannot grow and they won't unite. The fragment would result in a non-union. Other option, if it's an asymmetrical growth of the physis, this can present with an angulation, which can later on present with a massive genovarum or genovalgum. Then if it is affecting the knee joint, which is actually in the lower limb, the most of the growth is actually occurring, almost 80% of the growth is occurring in the distal femur and the proximal tibia. So almost 10 mm or 1 centimeter of growth occurs at this knee joint every year. So we have to remember, if this is affecting the physis of the distal femur, the proximal tibia, this can lead to a disastrous problem, because this would eventually lead the child would develop limb length discrepancy, which could be as high as 6 to 8 centimeter, 10 centimeter, which would be massive rather. And usually premature fusion, which can occur because once the physis is effective, there is no growth and this leads to fusion, and then this can also retard growth and eventually leading to LLD. Thank you very much. In this section, we have briefly gone through the physeal injuries, and we have covered the Salter classifications of it. That is mainly the type 5 types. The type 1 is through the surface of the Physis type 2 is actually the fracture is going into the metaphysis. Type 3 is going into the epiphysis. Type 4 is a through and through fracture which involves epiphysis, physis, and metaphysis. And type 5 is actually the crushing of the physeal injury due to compression force acting on it, which is actually not which can be reviewed retrospectively once the angulation has developed, and we probably can come to know that there was a Salters type 5 injuries which was initially missed. Why it's important to deal with these injuries? Because physis is actually the part which is making the bones grow. Eventually there will be a lot of complications, especially in form of LLD, angulation, and problems for the child when the child is growing. So we need to manage these injuries. If they are undisplaced, the management option could be form of splintage or POP. If they're displaced, then closed reduction internal fixation with smooth K wires or even the screws can be done. If they're displaced, open reduction internal fixation with smooth K wires and screws can be done as well. When we are using screws or threaded K wires, we have to make it sure that we do not cross the physis. If we have to cross the physis during our the configuration of fracture is such, then we must use smooth K wires. Thank you very much. Keep watching sqadia.com.